I'd just like to also introduce Alex Brown. He's the research program leader at SAMRI, and he's actually worked up here for a fair while doing clinical and population health infectious diseases work. He's had a focus on heart disease, diabetes, depression and chronic disease in health services research, and he's going to talk on that today. Thank you, Alex.
Thanks, Bennett. Look, thank you very much for the opportunity to speak here, and it's a bit of a homecoming, having left Alice Springs a couple of years ago to take up residence in Adelaide after really 13 and a half years of a pretty long and arduous apprenticeship here in Alice Springs. Good to see a lot of friendly faces from years gone by, and it certainly is a great honour to be welcomed here and to be able to speak on Aranda Country. Given we've got some time constraints, I'll try and funnel through some of this talk fairly quickly. Some of you in the room would have heard about some of this work that we've done with Aboriginal men a number of years ago, but it's always important to reaffirm the narratives we get from Aboriginal men about the tough times they experience and some of the consequences of these in their lives and the lives of their families. So thanks for giving us a chance to talk through this. Now, where do we begin? We begin with really our fundamental interest in life expectancy differentials for Aboriginal and Torres Strait Islander Australians. This is a slide that I present pretty much at every talk that I give. Most people who have seen me talk are pretty bored with this slide, but it's an important touchstone for our work because fundamentally it defines what our target is. If the life expectancy gap for Aboriginal and Torres Strait Islander men and women in this country is anywhere between 15 and 20 years, the fundamental question is what drives that gap if we're going to make a difference. And really it's chronic conditions. Chronic disease, more than anything, accounts for about 80% of the life expectancy differential. So diabetes, heart disease, kidney disease and chronic lung disease really are the drivers of the gaps that we see in outcomes for our people. That's where we began. Now, what are the consequences of this gap? Well, it's very easy to think about the impact on the numbers, the sorts of life expectancy figures we see, the mortality figures we see. But it's only when you really talk to communities about how you get a sense of really how much chronic disease is influencing our lives every single day. We recently completed a large piece of work speaking to over 200 Aboriginal and Torres Strait Islander people all around the country and asked them a very simple question. Do you know somebody in your community or in your family that experiences chronic disease, like diabetes, like heart or kidney disease? And the response was fairly simple. Yep, all of them. There's not many white families in this country where you could have exactly the same conversation. So for all the data we present, all the data we collect, it really doesn't get to the heart of the real impacts of chronic disease. And importantly, we haven't yet found the right targets to reduce the unequal divide between Aboriginal and Torres Strait Islander people and everyone else. And that's really where we began. The work that we progressed, starting in about 2003 here in Alice Springs, was a simple question, or a seemingly simple question at the beginning: what drives cardiovascular differences as experienced by Aboriginal people? So why do they have so much heart disease? Why are they more likely to die than everyone else? And we broke this into a few bits of work. We focused on understanding risk factors: smoking, high blood pressure, total cholesterol, high levels of fat in the blood, to see if these could account for the differences we saw. We also had a particular focus on how well the healthcare system did its job. Was the healthcare system responsible for gaps between our mob and everyone else? Was everyone getting access to the care that they needed? Were they getting the right sort of therapy at the right time? Were there any factors at play that meant that Aboriginal people with certain conditions didn't get access to the best quality care that everybody else could hope for? And really what we wanted to focus on is not just looking and holding the lens to the system, but helping the system to make the job of chronic disease a little bit easier. The other piece of work was really to try and understand the impact of stress and worry and grief and loss on Aboriginal people's lives, and particularly its impact on driving the development of chronic conditions, and importantly influencing outcomes for those who have chronic diseases like diabetes and heart disease. And really that's what I'll try and focus on a bit today. But probably the 800-pound gorilla in the room is, what in God's name are we going to do about it? It's very easy for research to find a question that is, well, what could be possibly driving this particular circumstance or this particular condition. It's a much harder question to say, what are we going to do about it? And we'll touch on that a little bit later. Really to help build better systems of care for all Australians. So we have this question. Well, really, this was a question given to me by two old men who have now passed away. The two Mr. Rabunges, who the building is named after, the Baker IDI and Flinders University building on the Alice Springs Hospital campus, who said to me, well, my boy, if you're interested in understanding why we've got so much chronic disease, you need to look at the stress story. The worry, the grief that we carry is the reason we have so much disease. I thought, oh my God, I don't know how to answer that question. So I went to the community and I asked them in the first place. This is a painting put forward by Andrew Japaljari Spencer, police aide at Kintor. I said to him, well, these old men have told me I have to look at this, and he said, oh, well, this is easy, Alex. We've known about this forever. If you look at this painting, what he tried to do, and it's not a sort of a traditional painting, it was really a painting to try and explain something to me because I was pretty young and silly and new to town. And he said, really, stress and worry is what drives depression as experienced in Aboriginal communities. And if you do get depression, you're much more likely to have a heart attack. And the reason is you're not as likely to take your medicines. Your heart becomes out of balance. Your sugars are out of control. You're less likely to lead a healthy life. You're not going to take medicines. You're more prone to infection. So really, it makes perfect sense to us that if you're stressed and worried, you're more likely to develop disease and you're more likely to succumb to it. So this was really the beginning of this journey. Where did it go to from here? Well, we spoke to a whole bunch of people in the desert. We looked at the data to try to get a sense of, is there really a story here at play? And really there is. The reason we're interested in the links between stress and worry and physical illness is because most of the medical community doesn't buy it. They don't believe it necessarily. But we will see in 10 to 20 years the expectations that chronic diseases like heart disease, conditions like diabetes and depression will be the leading causes of the global burden of disease. That is, the highest impact in the experience of death and sickness for all people in every country across the globe. So it's important. What else did we find? Well, we found that this is not a new story. If you look at the Bible, and I have to admit I don't read the Bible particularly often, but in terms of my PhD work I did, and you'll find through the Bible references to heart and mind and the interconnection between soul and spirit and well-being and virtue are used interchangeably. There was some very early work in the late 1800s by a very famous doctor in Canada, a guy called Osler, and he was really the first guy to start talking about heart disease. And he talked about heart disease as only occurring in men who were very stressed, worried or sad. So there was a whole scientific body of work beginning, but fundamentally science has been a very long way behind the way in which communities understand and people understand these very strong links between grief and loss and physical illness. What do we know about patients who already have heart conditions? Well, it doesn't matter which one you look at. If you've got a heart condition, you're much more likely to have depression. You have elevated depressive symptomatology, so that is at mild levels, but you're also more likely to have severe depression. So this is a consistent feature across populations all over the globe. Some of the most important data, though, because you have to convince doctors of a whole range of things. We're very stubborn when it comes to really listening to other people, it seems. I blame our training, but most people say it's part of my personality. We'll get to that later. But fundamentally, it takes a lot of convincing. And this is really the first bit of work. These are curves that show how many people are still alive if you follow them over time. And these were patients who had had a heart attack in Canada, and what they did was measure the amount of depression that they were experiencing when they had their heart attack. And the people with the highest depression scores had the worst survival. So they were less likely to make it. They were less likely to survive over the next 3 to 4 years. And in fact, people who had depression were 4 times more likely to die. So this is a very strong signal. This is probably one of the first signals that there was something important to progress here. But proving this is very difficult. And science, medicine, asks a lot of questions and expects you to have a whole lot of answers. But it's very difficult. It's difficult to measure what we mean when we say stress. I'm really stressed out. What exactly does that mean? Well, we're not sure. It's very hard to take into account the changes that people have over their entire life. So if they're exposed to very difficult circumstances as young children and then have things much better in an older age group, how do you account for the way in which things change over time? Similarly, people who are stressed out and worried or have grief in their life or experience depression are also more likely to have other risk factors playing. So they're more likely to smoke, they're more likely to drink high levels of alcohol, they're more likely to be unhealthy for a whole range of reasons. So maybe it's not the stress and worry that drives it, maybe it's all these other things. Similarly, it's very hard to understand what we mean when we say depression when you're working across cultures. So, do Aboriginal people understand what depression is the same way a bunch of white fellas who sat in America and wrote a book on what depression is? Are they different things? We needed to test all of these questions. Similarly, some people would suggest that it's all poverty and disadvantage. It's not actually the link between depression and heart disease playing out here. It's really just disadvantage that's making things tough for you across your entire life. Similarly, no one can agree on how these things might all be connected together. And it's very important and useful to try and understand, if we think things are linked, how they could be linked, so you can target the right interventions, you can do the right things to make things better. This has always been difficult. And similarly, we know that things operate a little differently in Aboriginal communities. The way in which money operates to protect people from illness is different in a remote community as it is for a white fella in Vaucluse. You can stand on the corner of the street in Sydney with $1,000 in your hand. People will ask you to buy them a drink, but they won't feed along and take $50 each because nobody else in the family's got enough money to make it through to the end of the week. So the dynamics of income play differently for our mob, and it's hard to take all of those things into consideration. We also know that childhood matters. Early exposures to adverse things or bad things happening to you when you're a child can have a lifelong impact. This is data from America. What they did is they talked to about 10,000 adults and they asked them if they were exposed to tough times when they were children. And the more tough times that these adults were exposed to as children, and when they were adults, they were much more likely to smoke, they are much more likely to be depressed as adults, they are much more likely to be angry about their life, and they are certainly more likely to be obese. So there is a context to the behaviours that we as health practitioners always tell our patients that they have to get better at. There are reasons that people's behaviours are framed the way they are, and we don't really have very good responses to them. Now, as was mentioned in the last talk, there are some ways that these things could be connected. There are effects of chronic stress and negative emotional states like depression and distress that could influence the way in which the brain operates, the way in which the body operates. We certainly know that people who are depressed are more likely to have dysfunction or the inability of things to operate properly that control your blood pressure, control how well your blood vessels work, control how you handle sugar, how your metabolism works, how thick or sticky your blood is. So there are a range of influences that can play from stress and worry and grief and loss. What we wanted to do was find out if this was happening to explain the high rates of disease we see in Aboriginal people. But we were worried how we were going to measure the unmeasurable. What scientists hold stock in is only what they can measure, but you can't measure the mind or the spirit. You can't weigh it, you can't deconstruct it. But only if we do will they see that Aboriginal people are the spectators to the death of their culture, their lives. We watch as our culture dies. How are you going to measure that? And I didn't know. So I asked the smartest people in the desert, and they told me. So we did this piece of work, focused on Aboriginal men in Central Australia, in the bush, in town. We focused on every piece of literature we could find. We spoke to nunkeries, we spoke to senior men, we spoke to young men in town and in bush, and we did a whole bunch of work to try and understand this story of what distress and depression might be in Aboriginal men in Central Australia. And what did we find? Stories like this. All my friends I grew up with are dead, and I'm 53. I survived because I knew how to live like a white man. I behaved myself, hid my identity, paid my rent in advance. I never denied my culture or my relatives. I just had to see them in dark places. And similarly, depression is continual in Aboriginal people's lives. It is the struggle from birth to death. The struggle forever and a day just getting recognition that you're a human being. It is the shadow that follows us. It's forever there. Now, what did we know? Well, a bunch of scientists and psychiatrists got together and decided that there is a way of classifying what depression is from a white fella perspective. There are a range of symptoms, there are a range of behaviours that play. What we needed to do was understand if this played for Aboriginal people. And in many respects they did. There were just different ways of expressing them. You can talk about great sadness or grief. It was more, in Pindara anyway, jitteru jitteru, great sadness. So there were many similarities, but there were some striking differences, particularly in men. Anger and violence, rage, drug and alcohol use were very important markers of distress and depression in Aboriginal men. As far as men were concerned, this was the story. Stress, disadvantage, oppression, being fundamentally screwed over were the drivers of depression. Depression led to a whole range of sadness and worry, which weakened their spirit and had influences on their emotions, but also their physical health. This was a very important connected cycle. So what did we do then? We tried to take this into the field. We wanted to know if stress and worry played in understanding heart disease and risk in the community. We did about 40,000 Ks. We recruited 186 men and a bunch across a whole number of communities, and many of those communities are represented here today. What did we find? We found that Aboriginal men in town had much higher levels of stress. They were more likely to be thinking about suicide. They were more likely to have depressive symptoms. They were more likely to be influenced by having family taken away. They were more likely to feel that they'd been screwed over in their life. And this was important. The sort of stresses that these men were facing were very significant and very severe. 50% of men said that they lived in a high-stress environment. 50% of men said they experienced enormous worry for their family every single day of their lives. 30% of men experienced racism every single day of their life. And why did this matter? Well, if these things were playing, you were much more likely to have elevated depressive symptomatology. So if people didn't have somebody close to them, they were much likely to have depression. If they didn't have all the things they needed in their lives, they were more likely to be depressed. If they didn't have enough money to survive day to day, they were more likely to be depressed. If they were treated badly by the police in Alice Springs, they were more likely to be depressed. If they experienced racism and grief and humbug, they were more likely to be depressed. These are important markers of stress and distress in Aboriginal communities. And why did this matter? It mattered because if you had depression, you were 10 times more likely to have heart disease. And this doesn't tell us that depression and distress leads to heart disease, but they're important bedfellows. And if we don't have chronic disease systems that include social emotional well-being in them, we've missed the boat. Similarly, the strongest correlate of obesity, so people carrying too much weight, was in fact depression. In a linear relationship, which means for every bit of obesity, every bit more weight you're carrying, your depression rates were much higher as well. Similarly, it was the strongest predictor of somebody being a smoker. If you were depressed, you were 8 times more likely to smoke. Similarly, you were 7 times more likely to drink alcohol at harmful levels. These are the fundamental things that we tell all of our patients to change. We never ask them about the distress and worry in their lives. We never try and impact on those things. We then replicated this work in Aboriginal men and women in Central Australia in the Heart of the Heart study and found important associations, high risk in these communities, but importantly, depression was an important marker of heart disease in men and women. Not to the degree we saw in the first group, but certainly was there. So what are we doing? Well, what we've been able to do is measure stress and worry in people's lives, and we're going to follow up all of these people now 6, 7, 8 years later to see if stress and worry drives the development of disease, so that we can then try to build better ways of intervening in primary care. We've done some observational work, the cohorts I just mentioned. We've developed some trials and clinical registries where we've measured stress and worry, and we also want to build interventions moving forward. We think those interventions have to be in primary care. They are the right place for it. There is not a great deal of evidence about what works to improve chronic disease outcomes by focusing on social emotional wellbeing, but there is some emerging evidence. The question is, if we reduce depression, do you also reduce mortality from chronic disease? And the jury's out. We think, though, that there are ways that the Aboriginal community can help define better solutions for integrating social emotional wellbeing and chronic disease care. We've got 4 projects running at the moment. One is a nurse-led model of care for patients having a heart attack. We're focusing on social emotional wellbeing in those individuals. We've got a trial just beginning in South Australia of omega-3 fish oils to improve outcomes. We have a case management model of care in Inala, and we're just doing some validation work on the depression score. The question we have is, what's the right intervention? How do we make sure we embed culture? And what's the right workforce to move forward? So that's where we're going. We'd certainly be very keen to talk about the results of those soon, and then talk together about what's next and what we can do together. Thank you.